We are live.
Hi, good evening. This is the 7th monthly meeting of the Noida Ophthalmology Society, and today is a big day for me personally to have some of the people who have this. I have a very, very high regard. You know, I was Professor Amod Gupta and Dr. Vishali. Professor Amod Gupta has been, like he's a teacher of teachers, and to me, I've always told him that I'm his eklavya student. So the pattern for this meeting would be that we have two talks, first by Professor Amod Gupta, then by Dr. Vishali. After each talk, we have about 5 minutes of discussion, followed by the next hour is a question answer session where we have selected questions, and we have a panel of uvea and retina specialists who will be asking these questions to Sir and Professor Vishali alternately. If there are any questions on the chat box, please put them on. We will take it to the doyens of uvea. Let me now share my screen and introduce the speakers to you. Actually, they don't require an introduction, but nonetheless, let me do that. Can you see my screen? Is it visible?
Yes, Dr. Ajay.
Right, yeah. So Professor Amod Gupta is Professor Emeritus, Advanced Eye Center, PGI, Chandigarh, India. He was the head of the Department of Ophthalmology for 20 years. And he built the department of PGI brick by brick for all these long years. He was the founder president of the USI and past president of the Vitreoretina Society of India. He was Dean PGI from 2011 to 2014. He's an elected fellow of the National Academy of Medical Sciences and received the coveted Padma Shri in 2014. He has given numerous orations all over India. Every state he has given an oration, including the Vijayananda Patnaik Oration Award of the VRSI in 2011 and the Von Sisley Medal and lecture of the German Ophthalmological Society in 2015. He has over 11,805 citations, published over 385 peer-reviewed publications, and has co-authored 3 widely read books on diabetic retinopathy, uveitis, and OCT. He has described a new entity called presumed tuberculosis subgenus like Corroidopathy in ophthalmology in 2003. He is a personification of persistence, diligence, hard work, and teamwork. He's highly respected teacher of teachers, and only a lucky few have been able to spend great quality time with him as students. Others, like most of us and myself, have been his eklavya student. Thank you, sir, for gracing this occasion and agreeing to be here. And thank you, Dr. Vishali. I will, Dr. Shahana, can you please introduce ma'am?
Well, I think she was the best person to take on the mantle of PGI Department of Retina and Uvea after Professor Amod Gupta retired. She is a person with immense knowledge, great clarity of thought, and can simplify the most complicated of questions and patients for us. Needless to say, she has numerous publications, lots of very, very well-read books. She's given over 870 invited lectures, more than 7,000 citations, and all that. But she's also a member of the most highly prestigious Jules Gonin and Macular Society and recipient of several awards. She also has a US patent for her wonderful multiplex PCR. So I think we are extremely fortunate at Noida Ophthalmological Society meeting to have these two great doyens with us. And as Ajay said, instead of having the usual format of cases, etc., what we are going to do is we are going to make full use of their time and eke out answers to commonly faced questions in patients with uveitis. So I hope you'll enjoy this new format that Ajay and I have created. So welcome both of you.
And let me also say that this meeting actually hats off to Shahana for persisting with me for late night messages, early morning messages, long chats at finalizing all things. And you know, it's her baby of uveitis is her baby.
Oh, yeah.
And you know, it's Thank you, Shahana, for doing what
So if there is any flag for the question answer format, I am to blame. Yes.
Both of us are to blame. Yes, sir. We can start with Sir's presentation.
Well, thank you, Ajay and Dr. Shana, for asking me to share some of my thoughts on this very vexed clinical problem all over the world. Perhaps the most complicated among all the ophthalmology challenges. So I'm going to be giving in this brief 25-30 minutes some historical perspectives which are interesting, the epidemiological aspects, and then briefly describe what is the current understanding of all this. To go by the historical perspectives, I'm not sure how many of you are aware that even before Robert Koch described the AFB in 1882, 25 years, before quarter of a century before that, ocular pathology of tuberculosis had been described by Mainz, Von Greffe, and Leber. Interestingly, there was a guy, a pathologist, Haag, who had described 7 cases of tubercular choroidal granulomas in 1879. And immediately after, because it made a big, it was a very big event, there were a lot of press conferences held to describe AFB by Robert Koch. So he went back to his original 7 cases and slides and again reported them back again in 1884 and saw the AFB in those cases of ocular tuberculosis. Indeed, in the late 19th and early 20th century, it was believed that tuberculosis was the commonest cause of eye infection. And a segment of people seriously believed that the eye is the portal of entry of MTB into the system, and lung TB follows its entry from the eye. And so many people lost their eyes because of this belief around the turn of 19th century. Around that time only, the search started for studying the pathogenesis of ocular tuberculosis. So it's almost like 100 years that the models of animal models were made. Like in this patient, in this Finoff researcher, and interestingly, all these articles are available in the journal even now. In 1924, created a rabbit model by injecting the live as well as heat killed emulsion of the MTB. And he found that when he injected live bugs, all the animals developed tuberculosis. Most of them, in fact, died. But when he injected heat-killed AFB, the MTB, into the carotids, 70% of the animals, he could not produce really a model of retinal perivasculitis. There was no difference in the pathology between the live and the dead bacilli, except that in the dead bacilli case, the granulomas did not show the AFP. So this concept of the live bug or the live or the dead bug has been there for almost 100 years. So there's nothing new in this. Now, if I show you this table, it's a very complicated table, but I simplify. The left column here is those people who were kind of very conservative and they wanted a definitive proof of pathology in the eye of tuberculosis. So you can see the 2 to 10%, 11% cases in their clinics were ascribed to tuberculosis. But there was another band of authors, including Wilmer, who was the chief of the Johns Hopkins Eye Department at the time, who believed that almost half or 40% of their patients of uveitis had tuberculosis. And there were people in between these two figures. Now, Stuart Duke-Helder, he called his statistics a matter of faith than fact, and I 100% agree with his belief way back that what you believe, you start seeing that. It's a very interesting, Warhoff, you heard of Warhoff, he was one of the most prominent and dominant pathologists, ocular pathologist of US. He, in 1928, he described a patient who had a necrotizing retinochoroiditis called choroidopathy, and he presented the picture, this histopathological picture, and he said, well, this is choroidopathy caused by MTB due to hypersensitivity to MTB. Now, moving forward, year 1952, this technician, lab technician in the Armed Forces Institute of Pathology, Wilder, she described almost 53 eyes from the records of the Registry of Ophthalmic Pathology, the FIP, in which she described and she found the toxoplasma organisms. So it was a major breakthrough in the world because toxoplasma first time was described by her way back in 1952. Now, interestingly, all these patients, almost like half of these, 30 eyes of these had been previously described by pathologists as having tuberculosis or a possible tuberculosis, which turned out finally to be toxoplasmosis. There's a very interesting note by Lawrence Zimmerman, who remained chief of AFIP for several decades, when he was presenting a Warhoff lecture, and he reported this in 1973, and this is something which is 63, where there was a ritual of Wilmer annual event, and Dr. A.C. Woods, you know, Alan Woods, was the chief of Johns Hopkins Eye Department, the Wilmer Institute as it was called then, and he was the one who laid down the basic concepts in uveitis. And in one of his meetings in 1963, he was presenting, you know, the breakthroughs and observations on toxoplasma. And Warhoff, as was his wont, he jumped to his feet and said, look, you have ignored my observation made 25 years ago in that case report, 1928. People said this fellow has gone cynic, he's become senile because he was almost like 83 years old at the time. Except, he says, the only trouble is I called it tuberculosis. So there was so much. And he, 25 years after publishing his paper as a landmark paper in ocular pathology, he agreed that it was indeed toxoplasmosis and not tuberculosis. Now we go back and look at the TB etiology of uveitis, and Alan Woods presented several series between 1940 and 1960 when he was very active, and you can see the contribution of tuberculosis came down substantially from 80% to 20% over a period of 20 years. Now, this was ascribed to, you know, the discoveries of histoplasmosis, toxoplasmosis, sarcoidosis, brucellosis, and a variety of diagnostic entities emerged during these times and became popular diagnosis. But I look at it from another point, and if I juxtapose this chart, which shows the incidence of tuberculosis over 100 years in 3 cities, London, New York, and Cape Town, you would realize at the beginning of the 20th century, they had incidence of something close to 150 to 275 per 100,000 population. And this, because the disease became notifiable around that time, there was a continuous drop in the incidence of tuberculosis in their population. And this is here between 1940 to 1960. You can see the continuous decrease in the incidence of tuberculosis in the populations. So part of this explanation, 80% to 20%, might have been contributed by a decreasing incidence of tuberculosis in their population. Look at the London figures, Perkins described in about 8% in women and 5% in, this is about 61. You know, they were the guys, Alan Woods and Perkins, they were the guys who were contributing maximum literature on uveitis around that time. And he described all those infective, you know, pathologies as well. Now, major breakthrough was the development of anti-TB drugs, and of course, the compulsory notification, the beginning of the 20th century, which led to the decreasing incident rates. Incident is number of patients per 100,000 people, per 100,000 population who develop the tuberculosis disease, be pulmonary or extrapulmonary. So in next 40 years, from the 60s onwards, in fact, the intraocular tuberculosis discussion disappeared, virtually disappeared from the world scene until we started, some of us, we started reporting in the mid-90s about ocular tuberculosis. And this is what everybody is familiar, you know, it's the biggest, second biggest killer of, so it's a major disease. But when you look at, India contributes more than quarter of the total TB burden of the world. All these circles, you solid circles you see indicate like 2.5 million patients and above. And you can see in various countries, including China, these are the top 8 countries contributing to the majority of tuberculosis all over the world. And these are the incidence rates. In the darker green indicates a very high, more than 300 per 100,000 population. We fall in somewhere here, 200 to 299 patients. This was the incidence rate, mind you, at the beginning of 20th century in the developed world, the US and UK and the Europe. When you look at the population and contribution, this is the population here, blue bars. And you can see because the incident rate has come down, so the availability of uveitis, TB in uveitis patients is much less. And so is the India, large population, but very high incidence rates. And I'll show you again this chart. Why it happened in the US, in Cape Town, this is where 90s the HIV came, and they are still, you know, so much bothered about HIV and tuberculosis. That's the country which has a major problem there. In the US, on the other hand, we are so fond of US literature, their authors, and what they say is a you know, the paradigm, what they describe, we start believing blindfolded in all that without realizing that their incident rates, you know, have been consistently coming down. They are just less than 3 at the moment, you know, per 100,000 population compared to India, which has 200 plus incident cases of tubercular disease per 100,000 population. Now, given these figures, just to put the disease burden in perspective, that our disease burden and what we see in uveitis clinics is altogether different what they see in the US and other countries. Obviously, they are seeing less than 0.2% or 0.5%, less than 1% of their cases in the clinics are ascribed to tuberculosis. So is in the Europe. Key infectious uveitis, you can see the TB is way down, you know, this less than 2% around that figure. And so is in UK, Italy, Thailand, this is somewhere, you know, going up a little. There's a confusion about RIA. Besides, you know, there have been no diagnostic criteria. So confusion among diagnosis of TB uveitis has been, you know, marked by no definitive criteria. And for that reason, we have seen 0.6 from South India to 10% from our center, and Retinum is somewhere in between. So this is somewhere around that 6 to 8% would be currently the burden of TB uveitis in any tertiary referral center. Let's go with that. But it will be much less in a non-referral centers, in practices, and so this is what I wanted to show you here. The TB population, the bars, the high bars, like Philippines and South Africa, we don't have uveitis data, but for India, we have 204, and you can see figures have varied from 22%, current figures from North India, and to 19 and 13%. So as the criteria are evolving, people are diagnosing more TB uveitis in their clinic, but it at the same time corresponds to high incident rates. You know, we have the Myanmar, we have Indonesia, you know, Thailand and Vietnam. These are the countries, you know, afflicted with tuberculosis. And this is where you can see this again. I'm showing the same map, and when I map the TB uveitis prevalence in the TB clinics, in the uveitis clinics, you can see similar kind of it's overlapping there. So those countries, the lesson we learned, at least I learned, is those countries that have a high incidence rate of tuberculosis in their population, 150 and above and all that, have a significant number of patients in uveitis clinic suffering from tuberculosis. You all know it's very difficult to demonstrate AFB, or we don't really have, only maybe 20-25% would have radiological evidence of past TB, and there were no diagnostic criteria. But we were driven by this early 90s and even before 90s, we were driven by this necrotizing skin test, which I'm sure you see in your clinics as well. And that led us to think, is it really TB uveitis that we're seeing in the clinic? Can we find some evidence? And microbiological, I'm looking forward to somebody, who will come up with TB bugs culture from the ocular fluids, So can we look for the MTB DNA? That was a major question which we tried to address, and these are some of their publications. The first publication, it was very high, very nice, 58% positivity in those we suspected. But when we expanded the series, it came down to 37%. It stays around that. It's not a very sensitive test. People said you are using a non-standardized home designed PCR test. So why don't you go ahead with and do some more real time and quantitative PCRs? But this conventional PCR helped us to describe certain phenotypes, like clarify it for once forever that the so-called real disease is really TB retinal vasculitis in the majority of cases. And so was the serpiginous like choroiditis, the choroidal granulomas, and the entire works. So all those phenotypes, we had a helping hand from the demonstration of TB DNA from the ocular fluids. Of course, when people started talking about quantitative, we also showed by quantitative PCR, but all of them had suboptimal. And this is some of the examples which we published way back. And finally, the word was given by Nursing Rao group and the AFIP pathology, looking at the pathology specimen that they had collected over 75 years in the AFIP. And they say that with the current diagnostic techniques, we have a very limited sensitivity. So diagnostic techniques that we were using, PCR and X-rays and other tests and immunological tests, very low sensitivity. So what next to do? So we came up with now this widely accepted this classification of having a confirmed, probable, and possible tuberculosis. The confirmed is either you demonstrate an AFB or a culture, or you demonstrate at least the DNA of AFB. Probable is you have to have a clinical sign suggestive plus a radiological, or if it is not radiological and extraocular sites, you can demonstrate AFB, or you have the sputum positive, for instance, and at least one immunological test has to be positive. But possible is if you have a clinical suggestive, but one test has to be positive. Either immunological test, if it's not possible, then the X-ray has to be positive. So this is the least category which are possible tuberculosis. But mind you, all these three categories require treatment. These are some of the signs that we described over the last so many years. And these are now the phenotypes that are widely, I must say, accepted all over the world, endemic and the non-endemic world. And people have actually started seeing in their population uveitis clinic. But what is the current understanding? If I'm given 5 minutes more, I'd like to show you this 1991 report. This patient was reported, he was a necrotizing viral retinitis. He was being treated, and then they did a biopsy. When they did the biopsy, they made a homogenate. And in the homogenate, lo and behold, they found Gale-Nielsen staining positive for tuberculosis. MTB was first demonstrated in the modern era way back in 1991, 30 years ago. And then the patient was put on the anti-TB drugs, and this is very nicely healed, and patient recovered significant vision. Nursing Rao, it's a very interesting, it will take about 15 minutes to tell the story how Nursing Rao went back to one of the pathologist specimen and demonstrated the presence of MTB in the RPE cells. More recently, and this was a collaborative paper between Nursing Rao, between Padma Malani group, where patient had paradoxical reaction. The surgeon got scared because there was a paradoxical reaction seen in serpiginous like choroiditis. He went in to do a biopsy. The patient developed retinal detachment, came to Bangalore for fixing, They took a sample, they asked the Dr. Narsingh Rao to look at the pathology, and they demonstrated the AFB. They couldn't demonstrate the AFB. There was a necrotizing granuloma. They did the real-time PCR. It was positive for tuberculosis. The patient was treated with substantial improvement in vision and was reported 2017. Again, Narsingh Rao group with Johns Hopkins, they developed a guinea pig model by aerosol, and they demonstrated the presence of AFB in the parietal granulomas and in the lung and elsewhere in the systems. And this is from in the choroid, the AFB present in a guinea pig aerosol model. And there's nearly about 40% of the rabbits, the guinea pigs who were exposed to TB aerosol developed the disease. The current understanding is that RP cells having the phagocytic action, they play a major role. They harbor and they sequestrate the MTB. And again, a work from Dr. Narsingh Rao lab, where they have shown very nicely that the MTB is phagocytosed and acts as a reservoir. They stay there. They are they hibernate there. They stay there forever till they get active. So this was in a cell culture model of the MTB. We ourselves have shown that in patients who have latent TB, and we could get hold of the subretinal fluid while doing vitreous surgery, nearly 40% of them did show the MTB DNA in the subretinal fluid. Now, the most active person in the pathology and pathomechanism right now currently in the world is Somya Basu and his group, who have published very path-breaking papers, and they showed that when you expose ESAT6 and MTB RNA, double-stranded RNA, into the RP cells, they show activation of caspase pathway, which is a pathway for innate immune mechanism. So they believe that once it comes, we don't know still the trigger, but they start innate inflammatory process. How do they reach? And they have shown again in a zebrafish model that they don't mind the blood retinal barrier. Whether it's there or not there, it will penetrate, it will go across the RPE. More recently, they have also said that, well, the MTB could be traveling, and this is what they did again in zebrafish model, could be traveling in the phagocytosed state intracellularly or extracellular free, like phenolphthalein. So what they say that those MTB bugs that travel extracellularly and reach the ocular tissues, they are able to set up a very nice granuloma, TB granuloma in the eye, compared to those which come in a macrophage, which are not able to produce that kind of a big granuloma. So I think this is a very good thought. We have, in our group, we have shown that in a mouse model of TB that certain genes get activated. So we demonstrated those genes which got upregulated in the vitreous fluid of the mouse model, and 5 of those genes we also found upregulated in the vitreous fluid of our own ocular TB patients. In a cell culture model of RPE, they have again shown that the MTB genes get upregulated which are responsible for invasion, virulence, and intracellular survival of the MTB. And 2 of those genes were found again in ocular fluids from our TB uveitis patient. In the sense that it is not just bystander there, probably it is leading to expression of genes which are responsible for its penetration, virulence, for survival, as well as when there is an inflammation. So they are getting upregulated in the ocular fluids of patients. This is another very nice zebrafish experiment from Somya Basu lab, where it's shown co-localization of fluorescent tagged MTB to the retinal vessels and to the choroid. We have been looking at the immune profiling of the T cells that infiltrate, and we found that, well, there was a significant recently activated T cells, both CD4 as well as CD8, in the vitreous humor of patients. And these are, mind you, this interferon TH1, which is indicative of infective pathology, and IL-17, which is a marker of the immune mechanism. So probably both infective and immune mechanisms are playing a role in the causation of TB uveitis. The similar kind of work has been done by Soumya Basu, where he has used ESAT6 TB protein as well as the crude retinal extract to demonstrate that there are T cells present which react both to TB antigen as well as T cells that just react to and proliferate in respect to retinal crude extract, thereby again indicating that both are present in a given patient. Our group has also shown that T regulatory cells, which play a key role in autoimmune diseases like VKH and non-infectious uveitis, like ankylosing spondylitis uveitis and Behçet's disease. These Tregs kind of control the expression of the T effector cells. CD4 cells, if I can say, they can be broadly divided into CD4 effector cells and CD4 regulatory cells. So regulatory cells are very important to bring down anti-inflammatory activity, bring down or control the inflammation caused by either infection or immune reaction by the T effector cells, which express interferon gamma or IL-17. Now, we found in the blood of these peripheral blood of these patients with TB uveitis that the Tregs were dysfunctional, and there was significantly much lower frequency of these Tregs. In the sense that autoregulatory mechanism was a failure, which was leading to the expression of more severe inflammation in the eye, and a pro-inflammatory environment was created in the vitreous cavity. I would recommend towards the end for all of you who are listening to this talk to read this article, which appeared last year, July, in Tuberculosis by Dr. Soumya Basu, Paul L. Kington, and Narsingh Rao, which gives the current understanding of the pathomechanisms. And they have discussed very nicely. It's a longish article, and you must read it to understand if you wish to pursue research in TB uveitis or wish to remove any of your doubts about what you're seeing in your patients. So to summarize, the pathology of intraocular tuberculosis is similar to that in lung and other organs, and it's been well established for over 160 years. Nothing has changed except demonstration of AFB when Robert Koch described. It's also established that MTB spreads by metagenous route and seeds various organs. There's a lot of debate going on whether these are reinfections or these are reactivation. Earlier, we had all believed that this was reactivation of the primary TB, which we got some God knows when. But nowadays, there's a strong belief that perhaps because this is happening in the endemic countries most often, that this is the person is getting reinfected, because those which cause primary infection probably they are not, because they're getting it very quickly after exposure. The MTB reaches the RP cell where it gets sequestrated. We don't know what leads to activation of the innate immunity and then the adaptive immunity. They come in a sequence, and what causes that. We have demonstrated, both our group and Soumya Basu group, we have demonstrated that there is presence of autoreactive T cells as well as T cells which are coming from the immune as well as the infectious, the T cells like Th1 and Th17 cells, both are present. Their expression is there and their cytokines are there. What I said earlier, what's the tipping point? We still don't know. What causes the various phenotypes that I've shown you briefly? What mechanisms are available? We don't know. There may be kind of a balance between the infective element as well as the autoreactive or immune elements, or it may be, not an inflammatory response and not at all, something to do with the nod-like receptors mechanism in this. Thank you very much for this opportunity to share. I hope I limited myself to the time. It was kind of a run through, but you can ask me any questions on this later on in the meeting.
Thank you very much, sir. I think that was absolutely superb. I know we can go on for a long time, and you can probably speak for hours together on TB uveitis, because that is something it probably runs through your blood to teach people about TB uveitis. So one way of doing it is to have questions now, Shahana, or we can have Dr. Vishali present, because we're anyway going to ask a lot of questions
Yes.
to Southern ma'am in the
In the slides.
And that time we can bring up the questions so
Yes.
that there's a flow of thought process. So we could integrate it at that time. I think we can do that so that we can get on to the questions rapidly. So maybe we can request now Professor Vishali to share her thoughts on use of steroids in uveitis, particularly the intraocular steroids.
Thank you very much, Ajay, Shahana, and the Noida Ophthalmological Society for this wonderful meeting and for giving me the opportunity to speak. So I hope my slides are visible and I'm audible.
Yes, you are.
Yes.
It's very difficult to follow Professor Amod Gupta, So, but anyways, I'm just going to stay more with the clinical stuff and talk about intraocular steroids in uveitis. Now, Sir just mentioned before we begin the session that there are some patients who keep on haunting you in the middle of night as well. So this child was one of those patients. When he came to us, he looked like something like this. And unfortunately, he had Behçet's, a very severe one. And this was more than a decade ago. And we pumped in so much steroids to him that he ended up looking like this. And eventually, he lost his life. So steroids, giving a systemic one is not a good option, especially when you've got to treat on very long-term treatment, as majority of non-infectious uveitis patients would. So that brings up and opens up a new chapter, that is giving local steroids. So there are a few things we all understand, that local steroids do improve visual acuity, reduce inflammation, but you got to give repeat injection in case you wish to maintain the effect. And when you repeat injection, there are glaucoma, cataract, end-off, and then risk of detachment always there. So we do have implants, which is local sustained release, and depending on what implant you are using, it may be from 6 months to 3 years. And these are the 4 implants which are available, not all to us, but we have, like I have experience mostly with Ozodix. So my rest of the talk would be based on Ozodix, but anybody interested in any one of these, there is a lot of literature and multi-centric trials and everything on their efficacy. COVID brings another aspect to local therapy. So when we started seeing COVID last year, we realized that majority of our patients were in one form or other of immunosuppression, steroids, biologics, and we went into something called teleconsult, which I am fine with retinal, but for uveitis, that was not a good decision. Because many times the decision to titrate the therapy was being based either on looking at some images or telephonic consultation. Our physicians, because of the COVID panic, everybody tried to stop immunosuppression or reduce immunosuppression. So when we did this multi-centric trial, all Indian centers actually, HOPE study that we published in VJO, the aim of this study was to evaluate that what was the effect of change in the immunomodulatory and the therapies among patients, of non-infectious uveitis during COVID era. So what I want you to focus is the lines highlighted in yellow. What we found that 32% of all these patients had developed relapse of non-infectious uveitis, and 86% of these had relapses because the reactivation was related to altered immunomodulation. Like we were all confused. We did not know what will happen to our patients who were on methotrexate and this. So there was a lot of hesitancy to continue with immunomodulated therapy. So what do you do then? So this was more of an international experts consensus, where we did a consensus as to what should be the care of immunomodulatory therapy in patients who have non-infectious uveitis, again published in BJO. So again, please focus on the yellow because these are in context to the talk I'm giving. So the experts felt that if the patient has increased risk means the patient is non-infectious uveitis and is on immunosuppressive drugs. That is what we categorized as increased risk. So what they recommended that if such a patient has recurrence, prefer using local steroids over giving systemic steroids. And IV steroids were kind of a big no from all across the globe. And if, for example, patient develops COVID, then of course you have to stop many of these if your internist tells, especially during the early viral replication phase. So you may have to switch to local therapy. Then there was a second category of patient, which is high risk. High risks are the known risks for all COVID patients. So we are all familiar. I'm not going to read out for them. But if a patient who has any one of the risk factors and has uveitis, do not start new steroids. If you wish to, for a new episode, just prefer local therapy with steroids instead of, even if it's a bilateral disease. If patient becomes COVID positive, then of course, again, you don't have a choice. At many a times, your physician might tell you to stop during the early phase. And if it's a very high-risk patient, which has more than 2 hours on biologics, then again, you prefer local steroids. So I'm not going into the details of it, but just telling that local steroids or intravitreal steroids have become even more important in the COVID era, because I don't think COVID is going to go so soon. So the problem is the use of intravitreal steroids is less algorithmic in uveitis compared to the systemic steroids or immunosuppression or other things. So I'm not going to show you the algorithms because there do not exist any, but I'm just going to show you the indications where at least I found intravitreal steroids, and I have no financial interest, but I use only Ozurdex. I don't use triamcinolone. So all this experience is actually based on Ozurdex. The first is cystoid macular edema, which happens in eyes with non-infectious uveitis who have a minimum active inflammation, and you feel that it doesn't need any systemic therapy, especially if the disease is local. So you know there is some background vasculitis, but the main culprit here is cystoid macular edema. So this will be my garden variety of patient for giving steroid. And this is the opposite eye, which has nothing much going on. Even if there is some inflammation in both the eyes, I generally give a background immunosuppression, whichever is suitable for that patient, and top up the more severe eye with intravitreal steroids. This is the same patient, received one injection, responded, then 15 weeks later, second injection. So you may have to repeat it multiple times because uveitis is not going to go away. So I keep the background inflammation under check with immunosuppression so that the edema doesn't come back. But even if it is coming back and is showing good response to Ozurdex, you can repeat it comfortably. So to me, the first algorithm is if the patient has non-infectious uveitis, comes with cystoid macular edema, I would see if the cystoid macular edema is occurring in a very active inflamed eye or in a minimally active or inactive. If the background inflammation is not so active, local steroid implant is in itself sufficient. But if the disease is active, is it unilaterally or is it bilateral? If the disease is active unilateral, many times the implant would take care of the inflammation as well. But if you feel for whatever reason, systemic disease or, customized medicine, you need immunosuppression, you could have. If the disease is bilateral, I like to start my patients on immunosuppression and top up the eye which has CME with intravitreal steroids. The second category comes tubercular uveitis, and here comes the steroids and a big controversy. So like Sir has shown that this is not, TB is always not about infection or active infection. There are lots of immune-mediated mechanisms which are working in tuberculosis. So, these are the current three scenarios where we like to use steroids, intravitreal I'm talking about, in TB. One, we use it as an adjunct to ATT in reducing macular edema, vitreitis, and thirdly, which I find personally very useful, is paradoxical worsening, which Sir mentioned happens after you start anti-TB drugs. Now, this is a patient, cystoid macular edema, TB uveitis, has received ATT, so you give steroids, the implant, Ozurdex, and he's responded, so not a brainer. But only thing is, if you don't have active evidence of inflammation, it can be used. This is another patient of TB vasculitis, and you can see the vitreous haze, which was 1.5 as per some criteria, and we did not give any systemic steroid. We just added implant to ATT, and you can see the improvement in the media clarity and this mild leak which has disappeared. And probably if left alone, it might have developed into CME, but we could preserve a very good vision by giving a timely intervention. And the third is paradoxical worsening. This is something TB surgeons like. You add ATT and you are hesitant to start steroids. And especially in this COVID time, I would be hesitant to give 1 milligram per kg per day. But you simply put an implant in the eye, and this is the result you can get. So does intravitreal DEXA implant really add benefits? So we recently did a study which is submitted for publication. We had 25 subjects who had serpiginous like choroiditis, and we divided them into two groups. So one group, we gave the standard of care, which was the systemic steroids and ATT, and group two, we also received intravitreal Ozurdex implant. And we looked what impact Ozurdex implant had on choriocapillary flow deficit areas and visual recovery, and we followed them for 12 weeks between the two groups, and we found that the eyes that had received Ozurdex implant, you can see these areas of capillary flow void on the top, and below is the recovery of those flow void areas. So the eyes that received Ozurdex implant showed a much higher proportion of choriocapillary recovery compared to the eyes that did not, probably because you have a sustained high dose of steroids available locally that takes care of the inflammatory component. Third indication for me is relentless placoid, and we have this young girl, and we have a number of such patients. Right eye lost after giving ATT and everything. And she was even treated for atypical mycobacteria outside. So you name it and she's received it. And then she comes with the left eye. We did diagnostic vitrectomy, we did a lot of things for her, but eventually what has worked for her over a period of time is sustained steroid implant in the eye. And this is about 4 years later. She's maintaining a vision of 20, 30 healed scars. And, we repeat it whenever we are threatened because this edge does become active in between. Another case of relentless placoid, just to show you the example, once the infections and everything is ruled out, these are the kind of the patients. You see the center is involved and, it's going on and you can see the active inflammation on autofluorescence. So these are the kind of the eyes where now my first choice is Ozurdex. And this is pre and this is 3 weeks later. You can see on autofluorescence, the disease activity from the edges is becoming better. The fourth indication, and we are seeing now these patients, is the post-COVID vaccination recurrence of inflammation. So I'm just sharing these two patients, which would be appearing in JAMA ophthalmology. These were the two patients who had non-infectious uveitis in past, and both of them were very, very well controlled for more than a year. And receiving the vaccination, within 2 weeks of receiving the vaccination, they had the disease activity. This is the example of one such patient. Now she comes to us that she had poor vision in the left eye always, which was counting finger. And right eyes, she was seeing 660, but she said that after she's received vaccination, within 10 days, her vision is dropped down to 660. So this is what her scar was, and this is the edge which is active. Now, somebody may say, this edge is this, but the patient was really perceptive that my vision is calmed down. There were anterior segment, mild inflammation, some cells in the vitreous, not many. And this is the disease which was active. And this was the opposite arm, totally knocked off. So we just gave her intravitreal Ozurdex and she's back to 2400, but she's a happy woman because this disease progression at least has been stopped and we could halt the disease progress, whatever it was, without subjecting her to additional systemic immunosuppression. Another young patient, very well controlled since last 2 years, I think, and then within few days of receiving vaccination, develops activation. And of course, this is before Ozurdex and after Ozurdex. So I found it very useful in these patients of this. And this is 3 weeks follow-up. Following, you can see the implant here. And you can see the disease is by and large taken care of. And if it is an autoimmune response triggered by the vaccine, I think one injection would do the trick. I don't think they will need a long-term treatment in any form, though it's too early to say. Then we are also having very interesting new inflammations of RPE choroid following COVID, not the vaccination. Following COVID or vaccination, both actually. So this is another example of one young medical student, 25-year-old, exposure to COVID, receives vaccination and comes up with this. All investigations negative. So what do you do? I discussed with them, and this is just 3 days later. You can see, she's very smart girl. She says, my scotoma is going down and I feel happy. This edge is regressing and today has been 10 days and I don't have images to show, but she just sent me images from wherever she is that it's much better now, regressed. So I do hope that some of these are one-time events and we do not need long-term. So honestly, I don't. The sixth indication for me would be giving it patients who are undergoing cataract surgery, and we have reported that if we had uveitic eyes who were randomized to receive DEXA just before the surgery, I mean, it's perioperative, or they received the standard of the care. And I would like to bring your attention to the box at the bottom, that if you give DEXA implant, there is less post-operative flare. The recovery of the flare to preoperative value was very quick. And then 37% of the eyes developed CME in the standard of care group, but none of the eyes developed in DEXA group, which I think was a very important finding. And of course, the vision was better in DEXA. Sometimes I think we get too carried away, and this is one of the papers like I'm not super proud of. We thought that probably, Ozurdex was magic, and our cataract surgeons always love implants. It's the ego. So we thought that maybe we can get away in JIA eyes, putting the intraocular implant and giving the Ozurdex and taking very good care of inflammation in the post-op. But honestly, though we reported also that very good, but honestly, 10 years later, 12 years later, they are all doing bad. And today, whenever I have a JIA patient, I make it a point that no implants, Ozurdex or no Ozurdex doesn't really matter to me. My last leg of this, when not to use intraventral steroids, as Dr. Ajay pointed out, it's very important that you rule out infectious uveitis because even if you are not sure whether it is infective, non-infective, don't inject steroids in the eye. And secondly, if there is aphakia or pseudophakia, which has a very large posterior capsule vein, and this is an example, you can see the implant has been given in an eye which, is shouting infection on your face. So this example, you might have seen a lot number of times because we keep showing this. So this was actually a granuloma due to atypical mycobacteria, which got out of control because of the implant in the eye. And finally, we lost this eye despite multiple vitrectomies trying to save. And these are the, fluorescent images of atypical mycobacteria that were growing in that eye. This is again a report that Sir has reported. It's actually, unfortunately, the same child I showed my first slide, whom we had given systemic steroid, who had that hump and all, pushing oil, and then we thought, okay, we can give Ozurdex. And his Ozurdex came anteriorly because he had undergone lensectomy, vitrectomy, corneal decompensation had to be removed. So if you don't have anterior capsule, don't inject Ozurdex. So to conclude, be very judicious in patients with non-infectious uveitis, but it can be used for several indications, especially during COVID times. And do not use when either the diagnosis is equivocal or you have not been able to rule out infection. And it's very important to monitor these patients for any adverse event, as well as sometimes the disease may evolve. So you may have given Ozurdex, but the disease might evolve. So you got to, be very careful with these patients, even if you have done an intervention. Thank you very much for your patient care.
Thank you, Dr. Vaishali. I think that was fabulous, very clear, to the point, very precise. We can go on to the next session of questions, but before that, Dr. Shahana, do you have any questions for Sir?
Yeah, may I ask a question from Dr. Vaishali? So as you showed in your presentation that you came across this atypical mycobacterium infection where you injected Ozurdex, what about the garden variety of tubercular uveitis where we are considering injecting Ozurdex? Should we wait to somehow get proof that the AKT is working and shift from oral to Ozurdex, or we can go right at the beginning if it's a hypersensitivity kind of phenotype?
For serpiginous-like or multifocal kind of a variety, which does not have a volume to it, I just give also, I get a PPD skin test, quantiferon blood out. I inject Ozitex while waiting for the report. If report comes positive, I add ATT. If report doesn't come positive, I continue with this.
Right. And the granulomas and all that, of course.
Important message is, if you are giving ATT, just I have started writing on cards, unfortunately, please do not go to dots. They are making so many people blind. They have a fixed dose combination and they make sure that the patient eats ethambutol for 6 months.
Absolutely.
If not 9 months. And they keep on chasing the patient and it's very difficult. And we yesterday had one patient given for recurrent anterior uveitis by somebody, 6/6, 6/18 vision, and somebody started from dots and now counting finger, both eyes, So I would be very careful with this.
I think at least we can warn our patients about the ethambutol toxicity. True, true.
So, Dr. Vishali, I have one or two questions. One is the TB uveitis, I think we'll cover later on. You nicely covered about vaccination. So a patient who has had one single vaccination, had CME, you injected Ozurdex, and the patient comes back to you after 3 months, says, "Can I get my second dose?"
Yes.
What would you say? So would you re-inject Ozurdex and then give a second vaccination, or you would allow them to have a second vaccination?
I tell them that we already have you covered for the first one. So we don't have to do prophylactic, but I always encourage them to receive the vaccine and review if there is a recurrence again. Not all the patients have recurrence after second. I don't have too much experience, but these patients are coming. But I do not prophylactically inject steroids. I haven't done it.
Okay. We recently had patients who had cystoid macular edema, was waiting for cataract surgery. We decided that we'll give an Ozurdex to these patients and then go in for cataract surgery. Do you think it should be done at the same time, or one should wait for a little while? Because PGI has got a publication where cataract surgery and intraocular injection of Ozurdex was done at the same time.
Yeah, we do at the same time. I think it's more of a logistics if it is working for you, if you have different cataract surgeons are different. But be sure that cataract surgeons are going towards the vitreous cavity because they have a habit of taking their instruments like this. So we did have an incident where they put it in the bag and behind the lens. But whatever we have worked on diabetes and uveitis, we have done it perioperatively. Just before beginning the cataract surgery, they inject Ozurdex.
Okay.
But then you have to have a very expert surgeon. Because if you end up with the large PC rent and all, and Ozurdex comes in, really that can be messy. So I guess it all depends on your settings and your comfort level.
So in general, if the logistics permit, it's good. We can go ahead with an Ozurdex injection and later on go for cataract surgery, which will make it a little safer.
I guess so. There's no harm.
Right. So I think we can go on to the question.
One small question from Professor Gupta. So thank you for this outer space tour of how much labor goes into this diagnosing tubercular uveitis, the mechanisms. I was wondering, are there analogies from systemic tubercular infections regarding the hypersensitivity and the infective mechanisms, which could give a window to what's happening in the eye, sir?
The difference between the eye and the rest of the body is that the eye is an immune privileged site. So we cannot simply draw a parallel from the way tuberculosis develops in the lungs or other sites and the eye. So in fact, some of the observations maybe, the immune pathology, the observations are contrary to what we see in pulmonary tuberculosis. Okay, so
the CNS also.
Yeah, that is where we can draw some analogy from CNS. So it's probably the same setting as the CNS.
So can I ask you a question here? I read somewhere that when you have a spread of tuberculosis in Mycobacterium tuberculosis, of all the organs in the body, it is the choroid which has the highest circulation.
Sure.
So does that make it a privileged site because of the amount of circulation for the M. tuberculosis bacillus to come there?
You know, that's one reason for the bacilli may get trapped in the choroid and they find their way into the RPE where they get lodged. You know, but the funny thing about tuberculosis, we are learning, practically every day. One Mexican study, and there are a number of such studies that have been done on patients who are not dying of tuberculosis, but dying in accident victims, for instance. And they've done the autopsy and they've taken samples from different organs. And they find that they can, using multitude of technologies, molecular techniques, DNA. When a similar study was done in PGI from the harvested, I think Rima has published in some journal, Australian journal, where about 100 such eyes were taken, and they were looking for the presence of the TB DNA in the harvested eyes of patients dying in the mortuary. The difference was these were all very old patients, and they didn't find a single patient who showed the presence of. But in those patients, we had shown you the chart there. Those patients where we had taken the subretinal fluid sample from patients with reg RD who had the Montel's test highly positive. When we looked at their DNA profile in the subretinal fluid, it was 40% positive. Okay, the people have shown that the TB bug is present everywhere in endemic countries. Okay, where it will manifest, how it manifests, what triggers, nobody knows. So choroid is one favorite site, and more than choroid, it is the RPE.
Right, sir. So we can go on to the question.
There is one question from Dr. B.S. Goel.
I thought we just
sure.
Dr.
Sure.
Vishali,
Let's go in.
Back, we will take up Dr. B.S. Goel's question. So
okay, we can go to our session.
Let me welcome all the panelists. Dr. Shahana Majumdar, who needs no introduction. She is a consultant, VR consultant and UV expert at IK Hospital. She graduated, postgraduate from Mananzad Medical College, did a fellowship at Aditya Jodh, and from 2004 has been working at IK Hospital. Then we have Dr. Prashant Jain, who is a VR consultant at IK Hospital. Dr. Charu Malik, who is a VR consultant at Shada Hospital. We have Urvashi Goja, who is a VR consultant. Urvashi, can you put your camera on? Urvashi Goja, who is a VR consultant at Kailash Hospital. Dr. Anupma Pasni, who runs a prolific clinic. She is a VR consultant and was the secretary of Noida Ophthalmic Society before they took over. Dr. Anshu Arora, who is the joint secretary of Noida Ophthalmic Society and is a VR consultant at Neo Hospital. And Dr. Ruchi Tiwari, who is a young bubbling VR consultant at Tiwari Eye Hospital. So welcome you all for joining in. And Sunil, can we start the question answer session? So Dr. Vishali, since you were not here, there's a question from Dr. B.S. Goel who says, what could be the reason for flare-up of post-vaccination?
Vaccination does induce inflammatory kind of a response in the body. And there have been numerous reports of systemic flare-up of inflammation. So post-COVID vaccination, Dr. Carlos Pevesio from Moorfields is collecting cases under IUSG. And we have about 87 patients till last week from different parts of the world that uveitis, which has been controlled, gets reactivated. New forms of uveitis, including mostly anterior segment inflammation, new inflammations coming after vaccination where all other possible etiologies have been ruled out. So we don't really know what, I mean, we are still like, for me, I'm just keeping the samples in the biorepository. If someday somebody tells me this is the way to go, I will do. I tried doing PCRs from the vitreous and all. Padma Malini got one positive, I did not. So we are still looking at the profiling of these patients.
Thank you. So Neil, can you start the question answer session and put this thing? We can start the. Yeah, so when they go to the next slide, so that's a question for, so this is the format we are following. The person whom the question is asked to will come on your left. The person who is asking the question comes on the right. So yes, sir, this is a question to you. How will you approach a case of anterior uveitis who walks into the clinic? Will you investigate on the first time presentation? Then what is your approach towards considering patients to have oral steroids, or would you only use topical steroids? And we'll go over to the subsets of the questions of HLA-B27 being used, indications, and starting immunotherapy. So then you can take up the question.
It's for me?
Yes, sir.
Okay. So the major challenge I find that the emphasis in practices has been to straightaway order investigations and be in a rush to start a treatment, whatever. So my advice to all who are listening is that please take time out. I don't know how many cases you see every day, maybe once a week, or maybe once in 2 weeks, or once in a month, you see these kind of patients. They're not a regular patient, unless you're running a specialized clinic, you will not see a number of patients. Take time out to examine the details and characterize the anatomical location. Try to reach some kind of belief that this is probably autoimmune, or this is infective, or this is, it could be in older patients or very young children. It could be, we might be dealing with lymphomas and leukemias, and, so it could be masquerade kind of thing. So once you've decided, first you have to analyze, because anterior uveitis is a very vague term, unless you can establish by your examination. And here when I say examination, it means a dilated examination of the vitreous cavity as well as the retinal periphery. Because if you don't examine the retinal periphery, and you might have acute retinal necrosis developing due to herpes zoster, and the patient will present to you with flare and cells, and you're in rush to, send him to X-ray clinic or the laboratory, or start him on steroid, the fellow would go blind by the time he visits you next. So you must rule out any posterior segment pathology, because all inflammations in posterior segment in vitreous cavity eventually will have some kind of spillover inflammation in the anterior chamber. So you have to be very sure in anatomically localizing, is it localized to the anterior chamber? Is it localized predominantly in the vitreous cavity? Is it localized in the vitreous cavity? Then you characterize whether it looks like an infective, and we know the various phenotypes of infective. The top one is the viral infections and the toxoplasma. Once you have in the posterior segment, then you forget about starting steroids immediately. So once you are definite that this is an anterior uveitis, then you want to know what is the onset, what is the age group, is it male, is it a female, what is the corneal sensation, what is the intraocular pressure. You do a detailed workup. Most of these viral uveitis is missed out. It's most underdiagnosed. It's very frequently seen when you're trying to examine. Simple things like corneal sensation, intraocular pressure, will give you a clue whether you are dealing with a herpes anterior uveitis, okay, which is strictly a unilateral. Majority of cases will be unilateral. Now, if you find a person coming with acute pain, and he says, when I touch my eye, it hurts, and started at 2 o'clock yesterday, when he was doing something, and he put his finger to the eye and it hurt. Now, when you get that kind of abrupt onset, we call, okay, or another one comes and he says, comes sometimes in the right eye, sometimes in the left eye, every time, whether I treat or not treat, it resolves over 4 to 6 weeks. You are dealing with a very definitive, type of acute anterior uveitis, which is very often caused by ankylosing spondylitis. But if a female child is walking, white eyes, but cannot see because it's been pointed out by parents or the teachers, she can't see, she's coming with, some kind of band-shaped corroidopathy or a cataract in the hypotenuse eye, you are dealing with the JIA, which is a white uveitis. You will not see much signs of uveitis there. So try to characterize what is the onset, what is the course, put it that way. Okay. And now it limits you immediately, you look at, you see a hypopion uveitis, for instance, but in a 3-year-old girl. Now, there is nothing in a 3-year or 4-year child will cause hypopion. Okay, if there is no history of trauma, okay, then you start asking if the child has been having frequent upper respiratory catarrh or fever or not feeling well, not eating well. You need to rule out leukemias because that is how the lymphoblastic leukemia is present with the hypopion in one eye or both eyes. Okay, so these are similarly a guy who is 60 years, 65 years, present with a hypopion. You might be dealing with, again, lymphomas. So extremes of age, think of rule out masquerade, retinoblastoma, infiltrative uveitis in a 7-year-old girl, a 6-year-old girl would present as a hypopion, large cells in the anterior chamber. So we need to qualify what you are seeing. Now, this is, Ajay, I have seen my experience that nobody does. So many patients approach me, so many doctors approach me, they send their card. What is written there is the treatment prescription notes. Not a single referral I have received on my emails which has the uveitis characterized by physical exam or on slit lamp. Okay, that is the challenge.
I think, sir, it's very clear that we have to recognize, I think what we were discussing informally is to recognize the clinical patterns,
yes,
and characterize the clinical patterns into an entity and then go about proving it. You rightly said that rule out of posterior uveitis, rule out an infective pathology, and once you have ruled out infective pathology, you can then decide to treat according to the clinical pattern you recognize.
True.
I think next
I think that
question,
sums it up. Yes.
Yeah, next question, Sunil.
This is to Professor Vishali, and now we are zeroing down on viral hypertensive uveitis, which are unilateral, as Sir mentioned. Do you normally rely on your clinical judgment or a viral PCR to decide the antiviral treatment? And which are the ones you treat with antivirals, when and for how long?
Sunil, you please take up the question. Yeah, I'll repeat it if required.
No. I'm good. I was just thinking of sharing my screen.
Yes, you can. Yeah, sure.
In the meantime, I'm just going to answer this question. Viral PCR, has some of the very typical markers, which you can see, like what Shahana has shown beautifully. You have reduced corneal, if you have bilaterality, reduced corneal sensation, transillumination, you think more of herpes. But if you have unilaterality, the pressures are extremely high, and pressures are extremely high. There are some pigmented capes. Corneal sensations are normal. Try doing specular microscopy. If your count is also reduced, this is very characteristic of CMV. So I'm sharing my slide. We have recently, it's under review in JAMA Ophthalmology about proposed algorithms for management of CMV. Herpes, we have not yet finished. It's still under Delphi 2, but CMV is complete. So I can share with you the expert consensus. It is that if you are seeing a clinical phenotype like Shahana showed, which is suspicious of, let's focus on CMV here, which is suspicious of CMV anterior uveitis, mostly you would have unilaterality, raised IOP. And KPs which are stellate or which look different from the usual KPs. You do offer paracentesis, but that doesn't mean you will be able to do for whatever. If you can do quantitative, that is best, but at least qualitative is equally good. If you are not able to perform or you don't have the facilities or the patient doesn't want, consider treatment with both antiviral as well as anti-inflammatory, and you got to control the pressure. So the one part of your talk is answered, okay? Now your second part of the talk, and this is the green box on the side, what should be the suggested treatment? The first line therapy was topical ganciclovir gel, 0.15%, 3 times to 4 times a day for 1 month initially, and then you taper it to twice a day for 3 to 12 months. If you think necessary, and that necessity was actually most of the experts wanted to add systemic in recurrent episodes, not in the first episode. So if you want to start systemically, and it is CMV, oral vancomycin 900 milligrams twice a day for 2 to 3 weeks initially, and then you taper it to 450 milligrams once a day to 3 to 12 months. Again, the Europeans tended to treat it for, forever. But then Americans had a low threshold. They wanted to treat it for 3 to 4 months. So there are lots of regional variation, but by and large, everybody agreed about 12 months, 3 to 12 months, depending on the, here would come the role of the endemicity, pre, post test, but by and large, this was 1 year. I generally give it for 1 year. Okay. Anti-inflammatory therapy, topical predecetate, 4 times a day, you give it for 1 to 2 weeks initially, and then very slowly taper it. Many of the patients might actually need once or twice a drop, or sometimes even on the alternate drops to keep them going, especially viral uveitis. And anti-glaucoma topical beta blocker was the drug of choice. And I think I don't have to go into all detail. Your question is kind of answered with this.
Absolutely. So are we starting the antivirals to prevent recurrences and subsequent scarring of the trabecular meshwork? Or
to take care of to keep the disease activity under control. So if you can manage it just with the topicals, whatever type, customized dose, well and good. But if the disease is coming back, because every acute episode you will have will result in some ocular morbidity. So to prevent that ocular morbidity, you may wish to add, and CMV-rated anterior uveitis in particular, the glaucoma can be recalcitrant despite your therapy, and many of them would require glaucoma filtration surgery, which has very good outcome and should be done. It's simply because CMV you can't wish away many times with topical drops.
So Dr. Vishali, you said 3 to 12 months. It's a wide range. How do you decide when to stop?
That's what I told you, because there was Americans did not use it for more than 3 months most of the times. Europeans sometimes give it for 2 years. So this was more of a consensus. It's not a prospective data entry. So it's more based on the experience. Like in my experience, I think we need to give it for 12 months because after 3 months, patients do come back. So I reduce the dose, and I sometimes even keep it on once a day also. But we do give it for.
And if you give it for such a long time, the recurrences are less?
Yes. We are pulling out our data, though we don't have it as yet. This is just expert data. I mean, it's not a logical thing, but this is just my observation.
Shahana, can you go to the next
question?
Sunil? So this is to Professor Amod Gupta. Sir, what is the most common clinical picture of Fuchs in India? Do we see large KPs, vitreous debris? And do we look for a virus by PCR in Fuchs? Any role of antiviral steroids? And do we ever do PPVs of floaters?
let me just qualify it. I think a lot of us have an impression that Fuchs is almost very fine KPs, the vitreous is not involved. So I just wanted that to be clarified by Professor.
Jana and Ajay, it's very difficult to diagnose, and this, if I have to rate Fuchs uveitis as the most over-treated, because it doesn't require any treatment.
Exactly.
It's the most over-treated uveitic entity. So these patients who are young patients, they walk into your clinic complaining of difficult in vision, essentially because of cataract. So before they develop a cataract, they would hardly ever present with floaters. So they present with cataract. And brown irides, you don't see the heterochromia per se. So actually this term heterochromia, which we used earlier, has been dropped. Now they like to call it a Fuchs uveitis. Okay. And the way to tell the difference, whenever you see a young person with a cataract and you don't see, you don't have a history of trauma, you should put the patient on the slit lamp and look for very subtle changes in the iris crypts. Look at the pupillary border. Okay. Because that's where you would start seeing blunting of the iris crypts. You toggle your slit lamp from the right to the left eye and quickly see for the sharpness of the crypts and the dullness of the crypts. Then you start looking at the pupillary frill and you find that, well, this frill is missing. And you might see some of those, granulomas, discrete granulomas in the iris stroma or at the pupillary border. Now then you start thinking, well, am I seeing a Fuchs patient? That should be the topmost. And then you look at the back of the cornea. These are what we call stellate KPs. These are not large, these are small stellate. They have those, if you look into specular reflection, you will see those star-like appearance. Okay, they have those star-like spread. And they will be confined not only to the lower third and the Arts triangle, they're seen all over the back of the cornea. So you have now the triad of Fuchs uveitis, a cataract. There's hardly ever any flare or cells. Okay. Now there is no Seneca in this patient. So when you are looking at an anterior uveitis, you don't see Seneca and you see cataract. Because remember, in intermediate uveitis or splenitis or intermediate uveitis, the presentation is more because of cystoid macular edema. Here, they do develop cataract later in life because of steroids and because of persistent inflammation. But here, in Fuchs uveitis, the presentation is because of the cataract, not because of cystoid. These patients actually never develop cystoid macular edema. Okay, next you look at the vitreous. Now it is believed that practically every patient with Fuchs uveitis would have vitreous debris, would have vitreous inflammation. Filamentous debris, opacities would be present in the vitreous cavity. And, if you do a fluorescein angiogram, in Fuchs patient, you might see some little staining, mild staining of the optic nerve head, but you will never see a cystoid macular edema. In intermediate uveitis, on the other hand, you never see optic disfluorescence, you will see a cystoid macular edema. That's how they need treatment. That's why they have come to you. So these are the differences generally. Now, when do they become symptomatic for the floaters? Okay, now they become symptomatic for floaters is after cataract surgery. Before cataract surgery, their main complaints are confined to the cataract, scattering of light and all that. They don't appreciate. But immediately after cataract surgery, they start complaining, I'm seeing floaters. And that brings to your attention the fact that they have vitreous debris. Now, depending upon your confidence level, a lot of people, and there are a lot of reports now, they have started doing small gauge vitreous surgery, microincisional vitreous surgery, 25 gauge, remove the vitreous cavity. Okay, if I had it in my eye and I was very much bothered, I would get them removed. But generally, people will, these opacities tend to sink down, in the inferior vitreous stick. They don't throw those annoying shadows and they'll get along in their life. Okay, so you don't have to do an intervention, surgical intervention. I don't see any role for the PCR in any case. There is only the Singapore group, Soonfek T, who talks of a chronic CMV uveitis, which is we call Posner-Schlossman syndrome. which is unilateral and which has a high pressure. We knew it always as a transient intraocular pressure, large 1 or 2 kPs, and they have different descriptions for that. But apart from her, I don't think in India anybody has seen. I may be wrong, but whenever I have inquired on these formats, people who have seen a case, they have not seen where they could show a CMV positive by PCR. Okay, the other group is the rubella. That's the Netherlands group, where they have shown, and now that has been seen in other reports as well, even from the US, where remember they have shown it only by serology, by the anterior chamber, looking for the antibodies in the aqueous versus the serum, and if they have that ratio more than 3, you will consider that it's positive for those antibodies, not by PCR. So I would not subject to PCR. Okay, no way.
So will you do gonioscopy in these cases?
Come on, I mean, what do you want to see, those new vessels?
Those angle vessels.
I know, we used to see as a resident, and later, because in our department we were the first in the country to start talking about. If you look at our publications in 70s, we published our experience with Fuchs uveitis, cataract surgery, and all. So it goes back to almost 50 years now, our experience with Fuchs uveitis and PGI. Okay, and we used to look for those. And we used to look for that streak hyphema with LACA. Because, I mean, you don't need that. I mean, those were the days.
So when we were doing residency, in those days, they used to say the moment you enter the
hyphema.
You
have actually seen it.
I mean, why do you want to do that? I mean, because your telltale signs are right there written on the iris. And if you look carefully, if you know how to look for it, you will see the dulling of the crypt. When Vishali was talking about the viral anterior uveitis and iris atrophy, you see best on transillumination. You do an iris transillumination through the pupil, and all those areas of atrophic patches, and there are a variety of those iris atrophy. I'll not go into that in different viral diseases. You can. So what I'm harping is on clinical. You are a clinician first. You're a physician first. Spend time on this patient, maybe 20 minutes, maybe half an hour. Okay, don't be in a haste to scribble a prescription because you want to get rid of the patient. That if you want to get rid of the patient, then you start writing. Okay, otherwise you will spend more time on examining all these details.
Thank you, sir. I think we've answered.
Just a small point. I can't resist. Sir, don't you think Fuchs is the most peculiar uveitis of all of them?
It is.
It is. I mean, any thoughts? A quick one.
It is. No, it is. It's a very, very low-grade inflammation. It's a very, very persistent low-grade inflammation. Nothing will work, which is in response to the presence of the rubella infection in childhood. Now, in US, in those communities and regions, now we are hearing about anti-vaxxers and all those communities
where it's been vaccine gone down.
So in those vaccinated people, they did not see Fuchs uveitis. Okay, so those who had MMR, and not all of us had. I didn't have MMR. It didn't exist in those days. But even now, majority of our children won't have MMR vaccine. So we'll see SSP, we will see rubella, we'll see Fuchs uveitis, and in India, I think it's rampant. When I was seeing patients in PGI, I think I used to see at least 1 to 2 patients every week of Fuchs uveitis who had been loaded with steroids, immunosuppressive therapy, injections, and whatnot. Okay,
Next slide.
Thank you. Next one, Sunil.
Okay, so this is addressed to you. And we are opening the Pandora's box. So bilateral granulomatous anterior uveitis with a positive MON2, old Cox lesions on the CT chest identified. Would you treat with AKT or only if it recurs?
No, in the sense that once you have already said that you are diagnosing granulomatous anterior uveitis, there's a very little differential diagnosis to my mind of granulomatous anterior uveitis. Okay, and one is tuberculosis, as you said. The other, which can mimic the same, is sarcoidosis. Okay. And the third could be, which is pretty common, and that will not be only anterior uveitis, but that would be cases of recurrent weak age disease. Okay. Of course, we know that, well, CMV rarely may present like that, or you may have, not bilateral, of course, and then you may have some of the syphilis cases. All those we'll keep it for the time being out, because we're focusing on whether it's TB or sarcoid. So if you see those, what we call Berlin nodules on gonioscopy, Ajay asked me about the user role of gonioscopy. Here is the role of gonioscopy. Typically, sarcoid patient at 6 o'clock position would have those Berlin granulomas, which tether the peripheral iris to the peripheral cornea.
But how common are they, sir? Berlin nodules?
They're pretty common, I would say, if you start looking for it. With experience, you'll be able to see. You don't even do a gonioscope, you will start seeing, wow, the iris is coming into the anterior cornea, periphery of the anterior cornea. You'll be able to diagnose. Second discriminator, the best discriminator we found, because even on CT chest, you can't tell the difference between a TB and sarcoid lymphadenopathy, except, if you're a smart radiologist or a smart physician, you're seeing a lot of these patients, then you would see those matted lymph nodes. Matted lymph nodes in TB, and you would see discrete, large, what Professor Bhambre used to call the potato-like lymph nodes, swollen, big, in sarcoidosis. The discriminator is the Monto's test. If the Monto's test is positive, the evidence favors tuberculosis diagnosis. If it is negative, then we can be sure that this is a case with. Now, the trouble arises when in an endemic country like India, you may have patient of sarcoid with over-added, tuberculosis. Yes. So there the trouble arises. Okay. So there you need to have the expert opinion of the chest physicians who will help you in that. But these patients invariably would require steroids to treat, plus anti-TB drugs if you have Monto's positive. Monto's positive, we take it as plus 15 or more. Okay. Remember, we have been misguided all through our lives by some people who were reading very old textbooks. Okay. Key Monto's, you have received BCG in your childhood. Now, BCG after 5 years to 10 years will not produce a tuberculin skin injection more than 5 millimeter. You'll be positive in that. We don't consider 5 millimeter as a positive. Okay. We consider 10 millimeter if it is person is on steroids, immunosuppressive therapy, or HIV patient has 10 millimeter, we say, well, this is positive. But if it is 15 millimeter or more, the kind of reaction I showed you in our patient is necrotizing. There's no way you can maintain that necrotizing skin reaction, okay, unless you have humongous number of memory T cells and T effector cells, which will produce the interferon gamma there locally in the skin, okay, and produce that kind of reaction. That means there is the harboring an active infection. Since the question has not been settled whether the TB bugs are present in the eye, though there's overwhelming evidence for the presence of at least TB DNA, and in some of those large abscesses which were reported in the past, long time back, with the multiplying, replicating MTB, okay, which is present, okay, they are the ones, mostly would have a systemic disease or disseminated TB. They are the ones who present with replicating or multiplying MTB bugs. The other is the dead bugs, the presence, chance presence of MTB bugs, just the antigen is present or DNA is present and it's causing that. Okay, so I would like to eliminate the active infection present anywhere. And we have, if you read our paper on that, we've had asymptomatic patients going around, and when we were doing, we were trying to see CT scan roll and the lymph node biopsy, we found at least 12 patients who were absolutely asymptomatic, whom we could isolate the AFB from the lymph nodes, okay, using EBUS technique, endobronchial ultrasonic guided techniques. 12 patients with uveitis and presence of AFB in asymptomatic patients in lymph nodes. Of course, those were larger than 1 centimeter lymph nodes. So question is, you want to treat the patient, not the eye. So focus has to be always on the patient. Whether by a remote presence or by its own presence in the ocular tissues, we want to eliminate, be what the mechanism is. We want to eliminate the MTB. And these are effective drugs. They sterilize. This is the word used, is sterilizing dose of anti-TB drugs. Okay.
So, sir, Shahana, I think you answered, but in case the patient has a granulomatous uveitis, would you go whole hog to prove it by doing?
Come on. Do what? We have done enough of that.
And EBUS.
No.
Or would you start treating them?
Yeah, I would start treating them. I would I would have a physical exam done. I would have a CT chest. I will not order an X-ray chest, whatever people might say. And if you ask Salil Mehta, he would say, I would go to Havas. If I have to get a CT, I will get a PET CT. I will not have a high resolution or contrast enhanced. So that is the standard. X-ray would not show anything. So radiological test has to be either contrast enhanced CT, because that helps them to localize for biopsy if it is required, or a PET CT. Again, serves the same purpose. Okay. So I don't think we need to draw aqueous fluid or vitreous fluid for demonstrating in a given case on the first visit a granulomatous anterior uveitis to prove the presence of AFB, the genome, because the sensitivity I showed you that we were trying to do that for 20 years, we were chasing it. We could not prove in 100% sensitivity or reasonably sensitivity, like 80%, 90% of cases. If we had shown that, then would it become a standard test? Okay, but if you have a patient who is consistent with the clinical signs and tubercular granulomatous anterior uveitis, large KPs, the iris granulomas, talking of the anterior uveitis, or it could be, they could be having elsewhere in the choroid or in the retina or the, the optic nerve head. It doesn't remain limited to the choroid. TB granulomas have the tendency to infiltrate the outer retina. They may not come into the anterior retina, but posterior retina, they will involve invariably. I can tell you, sarcoid granulomas remain behind the Bruch's membrane. They don't invade. They will push the Bruch's membrane and RP complex forward. They will not infiltrate. So that's the difference. Okay. But of course, there are other signs for posterior TB choroidal granulomas and TB uveitis. We can see all that, the presence of intraretinal hemorrhages and presence of, what we used to call RAP, retinal angiomatous proliferation, causing those tiny type 3 CNVs. So it's typically seen in choroidal granulomas and not in sarcoid granulomas.
So at the end, the take home would be, once you diagnose the granulomatous uveitis, which you think is tubercular, clinically, you can get a PET CT done, but you will start the patient on treatment as a presumptive case of tuberculosis and add topical steroids.
First, you have to rule out VKH disease.
Yeah.
You have to be able to see the fundus all around. And if you are not able to see, at least do a ultrasonography to look for choroidal thickness. Because unless you have it in your mind, unless it occurs to you spontaneously in the clinic, that I have to rule out VKH disease, because VKH, bilateral disease, and young women would present exactly like TB. There will be no difference telling from the clinical exam unless you can show a choroidal thickness, you can show the, the typical presence of VKH disease, which has, these days people do OCT, but EDI, OCT, probably in significant inflammation may not be very good, but ultrasound is still the gold standard there. Yeah.
So Shana, can we go on to the next question?
Next slide, I think.
Next. Dr. Vishali, this is on intermediate uveitis, basically a bilateral intermediate uveitis, what all the etiologies you look for, which clinical sign would be indicative of which etiology, and the rest of the questions I'll read up once we... I have
once
to,
the answers start. Yeah.
Yeah, the intermediate uveitis, you basically look for the clinical clues. The first thing is you have to be sure the primary site is ciliary body. So vitreous inflammation or vitritis is the predominant event. And whatever is happening in the anterior segment is a spillover inflammation. So first, very important thing is to know what is intermediate uveitis. Once you are sure it is an intermediate uveitis, you look at the clinical aspect of it. Are there any areas of small little choroiditis patches, especially the perivascular one that you are seeing? Because intermediate uveitis is broadly of two types. One is the pars planitis, which is the idiopathic variety, and one is the intermediate uveitis as an expression of any underlying disease. So pars planitis would have a very characteristic picture that you will see the fibrosis, or even if not fibrosis in the early phase in the pars plana, you will have snow banking as snowballs tend to settle down there. And if it has been going on for some time, you may have even peripheral detachments, new vascularization or anything, but you will not see anything in the choroid. There should not be any choroiditis patches. When you do fluorescein, you would see vascular component because there is inflammation and it's a part of intermediate uveitis. Okay. Now the second is the intermediate uveitis, which could be related to an etiology. So if you have an etiology like small choroiditis patches, you would think of tuberculosis as a possible etiology. And for me, the clue for tuberculosis comes when I have these snowballs, the large one, somehow in TB, they keep on floating. They don't form the snow bank. So if I see snowballs floating around and maybe a posterior synecdoche, which should not be there ideally in intermediate uveitis, I tend to think more about tuberculosis as a possible etiology. I get a fluorescein done. If fluorescein also shows capillary non-perfusion in the periphery, so I go in direction of tuberculosis. If I have a pars planitis, which is very subtle yellowish lesions going on, some not pars planitis, intermediate uveitis, and disc edema, which is bilateral, I tend to think a lot about sarcoid as a possibility. And if I have a young patient who doesn't have too much of inflammation, but when you do fluorescein, there is a mild vascular leak in the periphery. I don't know. I tend to rule out multiple sclerosis, but that's not every day. It's just through sixth sense, maybe the patient profile, mild inflammation, multiple sclerosis doesn't come with a bang. So it has a mild form of vitritis and some vascular leak. So there I do get MRI done. And lastly, the syphilis can present as vitritis. So syphilis as a routine, we do in all the patients. Now, if it happens to be an elderly patient and, sometimes not even elderly, even in their 40s and 50s, first episode vitritis, which was never there before, I always rule out lymphomas because in the presence of vitritis, you can't really see those small little subretinal deposits. You can't appreciate. So my first line of diagnosis there is just to do vitrectomy. Even if I have slightest of suspicion, I just go and clear the vitreous, do IL-6-10 ratio, do 2-mid-88, do the cytology. And that's very therapeutic also, actually. You remove the vitreous, these elderly patients, you don't need to push in too much of anything, steroids or anything. So that's how I work with these patients.
So one last component of it, once you've treated all of them, there are vitreous cells. The vitreous cells may not totally disappear. They may persist. Does it really bother you?
If it's not bothering the patient, they don't bother me. There was a time when we were all chasing the concept of zero tolerance for inflammation, maybe 10 years from now. But now we are coming down to revise the criteria of minimally tolerable inflammation, because I think we all overdid. We all overdid with anti-infective therapy. We all overdid with biologics and all, trying to get rid of these cells, which were probably innocuous cells. So if their cells are, snowballs are not going to disappear, So if my patient is not showing vascular leak on fluorescein angiography, if patient is not having cystoid macular edema, if patient is not having anterior segment inflammation or disc edema, the presence of cells which have been persisting and not increasing personally doesn't bother me. But if it is bothering the patient, I do lots of fluotorectomies, 27G, just go and take out the vitreous. You are also happy, patient is also happy. And to be very honest with you, many times in these patients, we have never been able to get anything useful of the sample, Cytology shows some lymphocytes, something other than lymphoma, by and large, everything doesn't really add to the management, but patients are so happy after vitrectomy that it's kind of therapeutic.
So in most cases, we should try to attempt doing vitrectomy.
Yeah.
We can go to the next question. I think, thanks, Dr. Vishali.
Okay, now we move on to retinal vasculitis, and I see both names there. Any role of looking for systemic vasculitis? Because I see these numerous prescriptions with any, the entire connective tissue disease tests conducted in these patients. So please clarify that. And does Eales disease still exist? Sir, we'll start with you, please.
Me?
Yes, sir.
This Eales disease is the eponym given to Henry Eales, who was described this disease in young people, presented with vitreous hemorrhage, constipation, and all that. I mean, have you ever seriously asked any patient with constipation? No, those were the days when we didn't diagnose them much earlier. Now we've had experience and followed, and I showed that snapshot of my publication long time back, 2001, where we had shown that these TB vasculitis patients have extensive capillary non-perfusion areas in the retinal periphery. It's a occlusive vasculitis. It occludes the vessels, whichever it affects, and leads to neovascularization. And 150 years ago, perhaps the patients were not that smart. There were no facilities to visit. So unless they went blind, from vitreous hemorrhage, they won't report to a doctor. Now patients are very sensitive to even floaters, to even a slight decrease in vision. The visual demands have increased so that they report much early. So we don't really need to wait till they develop vitreous hemorrhage to be able to diagnose a Henry Eales disease. So anybody who's talking of Eales disease, an entity, is gone. Majority of those patients were TB vasculitis. And the jury is still open out, whether it is a infective, because recently, if you read a paper from Soumya Basu, he says you don't need to treat with corticosteroids. These patients can be treated only with solo anti-TB therapy, and they show an excellent response. So somebody has to replicate that study and see the experience. But traditionally, we have been treating them. And previous some of his publications just well said that these are the patients, they're trying to differentiate the phenotypes where the blood-ocular barrier is broken and where it's not broken. So the patient with vasculitis, the blood-retinal barrier is broken, where those who are presenting with choroiditis, serpiginous or choroidal granulomas, the blood-ocular barrier is still intact. So without going into details, he had earlier suggested that these patients would require immunosuppressive therapy, but now he comes with the fresh evidence that they don't need any corticosteroids immunosuppressive therapy. So, we need to be able to rule out, the characteristics of sarcoid. Let's look at the inflammatory disease, sarcoidosis. We know typical, those Candleback drippings. They're discrete. They're not segmental like what we see in TB. Okay, so these are the two diseases basically we want to tell the difference. The other diseases like SLE, would come with much earlier with cotton wool spots, areas of PAM or vascular occlusion, arterial occlusion, or a venous occlusion. Behçets are also again, would have right up to the capillary level. There will be a pan-retinal inflammation, and they have that. There's no choroidal involvement, by the way, in Behçet disease ever. So it's all retinal. So you can tell from clinical phenotypic present what we are dealing with. Are we dealing with DB? Are we dealing with sarcoid? Are we dealing with Behçet's disease or SLE or some of those, temporal arteritis or ANCA-associated vasculitis or, polyarteritis nodosa or, some of those diseases really don't produce retinal periphlebitis. They will cause retinal artery occlusion. They cause ophthalmic artery occlusion. They will cause, arteritic optic neuritis or optic neuropathy or ischemic optic neuropathy. Their presentation in the anterior segment, like the granulomatous polyangiitis, vaginal we used to call, would cause necrotizing scleritis, or it will cause an orbital granulomas. And there are, systemic features, renal involvement, upper respiratory tract involvement, the sinuses involvement. I mean, these are sick patients, who come to us. So retinal periphlebitis is really not a big deal when you start looking carefully. But if you have a brief glance into the retina and you say, well, this is retinal vasculitis, let's order 20 different investigations. I think when you have computers helping you or computers dictating treatment, this is what's going to happen. So again, the message is you are the physician. You should be trying to discriminate. Don't let the computer dictate you what should be done.
Okay. So that's the point I wanted to drive home. No need for that list of investigations.
Yes.
Just look at the phenotype.
Yeah, so look at the clinical patterns, recognize them, and then follow. Because if you see only in about 8 to 10% cases, the systemic investigation do reveal results. 90% they don't.
Ajay, see, the idea of any investigation, people order a number of investigations, 30, 40 investigations. That's an easy way out for them to get the patient out of the clinic. The basic principle of writing any investigation is it must help you in your thinking algorithm. I'm not saying computer algorithm. I'm talking of thinking. If I'm ordering counts, if I'm ordering sugar levels, if I'm ordering urine examination or X-ray or a CT or a number of investigations, what is the objective? How is it going to help me if it is positive? How is it going to help me if it is negative? So each, they order serum calcium level. How the hell are serum calcium or, the number of such investigations useless, rheumatoid factor. So long you're not dealing with the dry eye or a Sjogren's syndrome, why should you ask rheumatoid factor or you're looking at scleritis? I mean, this is where we have gone wrong because of our old masters, who had that. What I'm saying is the dogmatic. No, you must order. We have seen plenty of those in our times. Okay.
Yeah, so we can go to the next question. I think this question will come from
Dr. Prashant.
Prashant, you're there? Prashant, you have to read it out.
No, I can read it.
No, Prashant, I wanted them to.
Yes, sir. Yeah.
Prashant.
Hello, sir.
Yeah.
Yes, sir. There are certain signs which are highly suggestive of TB.
Absolutely.
Like conclusive vasculitis with CRA patches, choroidal granuloma, granulomatous uveitis. So would you consider AKT in this patient even without supportive evidence from Monto or CECT chest? Because most of the patient, they were unable to do CECT chest and all this.
No. You have to have simple skin test, tuberculin skin test, which government hospital won't cost you a penny. Okay, that's the simplest thing you can do.
Fine.
Okay, so you need to be able to defend your decision of starting a highly toxic, long drawn treatment, 9 months. Okay, and if the fellow is non-compliant and in future life is going to, develop a multi-drug resistant tuberculosis, you are putting his life at risk. So you must have some evidence. And I gave those brief algorithms. You can read that paper because it's now widely accepted. That is how we should approach. And that is actually adapted from the pediatric tuberculosis patients approach, because there also they are not able to demonstrate AFB, okay, or by histopathology. They are exactly the same as TB uveitis, okay, or pleural effusions, or these meningitis or meningoencephalitis. Exactly the same story as TB uveitis. Okay, so you must have one. The radiological, from extraocular sites, you demonstrate either pathology or the AFB, or you show a very, evident TB pathology on X-ray chest, CT chest, or PET chest, or the demonstration, or immunological test positive. So even if you are able to show one positive, not all the three areas positivity, you have a diagnosis of possible tuberculosis. But all these diseases, and now people used to question when we, long time back, 18 years ago, when we described this Sarcoidosis-like Corroidopathy, okay, they all were, critical, hypercritical, okay. That, how do you say it is tuberculosis and whatnot? Stuff like those questions arose. And there we actually had patients, if you read the report in detail, you will see patients who had been treated on corticosteroids. And they developed tuberculosis. And then we did the biopsy, we did the PCR. I mean, there couldn't be more better evidence disease entity described than those cases that we described in 2003. Okay, so you have to have an evidence. If you don't have evidence, start the patient with tuberculosis on corticosteroids, but keep that patient under watch for development, conversion of negative Montus to a positive Montus or positive IGRA or a positive CT, or development of systemic disease. You must keep under watch. Okay, don't lose the patient, send him on steroids and send him home forever. Okay, keep him under close observation, and the best is these days to document, take pictures. They will save your life, patient's life as well.
The next question is for Ruchir. But before Ruchir asks the question, I have a question for Sir. So this is normally when a patient comes to me for the first time, I've ordered MANTO test and I want to start steroids. And we say, okay, when we have your MANTO result, we'll start steroids then. Should we do like that, or we can have a steroid started and within 1 or 2 days, MANTO is not going to change? You see, this question remains open. Should we start first the steroids and then anti-TB drugs, simultaneously anti-TB drugs and corticosteroids, or first we start with anti-TB drugs and corticosteroids later? Okay, the fear is that if you start anti-TB drugs alone, the risk of paradoxical reactions, at least in serpiginous-like Corroidopathy. Okay, we reported 14%, but the next paper where they used, Vishali group used ultra-wide fundus pictures, 200 degrees, they found almost like 46%. I would go a step further and would say that and this must be discussed with the patient, that half the risk, 50% chances on anti-TB drugs plus inadequate corticosteroids, you will have flare-up of the disease, you will have paradoxical reaction, worsening, progressive lesions. Okay, so this nobody can settle unless you run absolutely controlled trial. And we did long time back a small study. We didn't really find any significant difference, so we didn't publish it. Starting steroids first, and then after 2 weeks starting the anti-TB drugs. Okay, there's no harm in starting the corticosteroids unless you are suspecting a replicating or multi-bacillary MTB, like an abscess or large granulomas, which are typically have that replicating MTB. So there's no fear. But if you are discriminant and like multifocal serpiginous choroiditis or multifocal lesions, I'm sure you can start with corticosteroids, and at leisure you can start the anti-TB drugs. There's no harm. Sunil, Sunil, can you have the question back? Richard, please go ahead.
Good evening, sir. It's a pleasure to listen to you always. I've listened to you quite a few times now. Sir, I have a few patients that I'm treating, and those patients are those patients who have already received AKT 15-20 years back with supportive evidence of tuberculosis, for example, a positive Montauk's test and a TB granuloma or an SLC type picture. But now they have recurrences. So is there any merit in going after looking for active tuberculosis again, or like we treat them with immunosuppressives and steroids and they do respond? What should we do in such cases?
So I would like to give the answer in two ways. Okay, as I said, previously till some years ago, we all believed that this is reactivation of the primary tuberculosis. Now that belief is getting phased out. People believe that in endemic areas, it is more likely to be a reinfection. Okay, so you have removed and this typically happens, after about 5 years or so, these kind of recurrences, right? So when they're happening after several years of first disease, which has been adequately treated with 9 to 12 months of therapy, which is required for extra pulmonary tuberculosis. I don't think we have time to go into the details of all those details, why they have to be prolonged therapy for ocular tuberculosis, like for bone TB or for brain TB, or, unlike pulmonary TB, which gets away within 6 months. Okay, so that is one reason, that it's a reinfection. So you need to treat it afresh. Okay. The other reason is if it is recurring within a short span, like within a year or within 2 years. Okay. Or it's responded immediately when you started, but after a while, after a few months, 3 to 6 months, you start seeing that the lesions are getting to activate. Okay. So within few weeks of starting, okay, you would have the paradoxical reactions, okay, which is Jarisch-Herxheimer kind of reaction. If it is happening few months later, okay, it could be development of multi-drug resistance. And you'll be surprised in our experience, and we are the only group which reported on multi-drug resistant tuberculosis in the eye using molecular techniques by gene expert, by line probe assay, by gene sequencing. We've shown that nearly 14% or roughly 15% of the patients, they would recur because of multi-drug resistant TB bugs. Okay, which is well known about pulmonary disease, is very well talked about, but ocular TB was the first group to start talking about multi-drug resistant. And these patients, they do extremely well in our experience, which we have published, I think now 3, 4, 5 papers on this issue from our group, where we have shown excellent response to MDR treatment. So we can have details of this on another day, if you really want to go into the details. Okay.
Thank you, sir.
Sunil, next question, and Shahana, after this, we can ask a question by Dr. Anshu also, so that nobody gets disturbed. Yeah, so you go ahead.
So we come back to sir again. Which type of tubercular uveitis shows most commonly the paradoxical worsening? And does paradoxical worsening after AKT or presumed AKT in a way confirm the tubercular etiology? This is a bit of a wacky question. In which tubercular uveitis would you use anti-VEGFs? And in which circumstances would you consider immunomodulatory therapy in TBU? I think a few of these questions have already been answered.
You see, the multifocal serpaginoid choroiditis or serpiginous-like choroiditis is the phenotype which shows the maximum rate of paradoxical reactions. I have seen one odd patient with retinal vasculitis showing the same response. I have not seen granulomas responding in a way, but those were early days. We were not thinking of paradoxical reaction. So somebody has to really document them now when they're starting their, treatment with anti-VEGF. Very nice work, I'm aware, Manisha Agarwal has done in our hospital. And they actually measured the VEGF levels at the time of giving anti-VEGF injections. And they have shown very, very high levels of VEGF in these patients with TB choroidal granulomas, which had been shown in animal models by nursing Rao. Okay, in the animal model, they have shown that these granulomas, hypoxic granulomas, they overexpress the VEGF as well as the hypoxia-inducible HIF factor in the retinal pigment epithelium and the granuloma. Okay, and they, once you have the VEGF or you have the hypoxia-inducible factor expressed in these granulomas, we know that this is going to invite new vessels. And that's why when I said, if you see those intraretinal tiny hemorrhages, which we, very often we dismiss them as of no consequence, or when you do fluorescent angiogram, I'm not talking of ICG, I'm talking of fluorescent angiogram, you will see immediately the flush of those vessels. It's a highly vascular granulomas. They are the ones which you should treat with anti-VEGF combined with all other therapies. And I'm sure Mohit Dogra with Vishali, they have some papers on the use of Lucentis or Avastin as a standalone therapy. These are called host-directed therapies. It's a new paradigm in TB treatment. Okay, and it's reviving the concept of taking them to the mountains, sanitarium. Yeah, so which is the oxygen-rich environment. Okay, because they realize that it's the hypoxic disease, even in the lungs. Okay, so hypoxia is the major issue, and you can deal with it. And I think we have reported, and I think I'm not sure if Kalpana Babu reported a long time back a similar case. And now I think Manisha has a large series of these cases where she has correlated with the VEGF levels and the granulomas regression. And as they regress, they have absolutely proportionally decrease in VEGF. And mind you, these are VEGF levels are way, way beyond what we see in ARMD or vascular occlusion or diabetic retinopathy. So these are they're full of VEGF. You'll be surprised when our paper comes, whenever it comes. So I've had a chance to look at some of those details, and it's very impressive. And actually, it impressed the guy who first, Ohlers, from Australian researcher in TB, who first gave the concept of host-directed therapy. And he said, this fits the bill, as host-directed. And we have seen that even the first patient we have reported after, I think they have now 7 or 8 years follow-up on that patient. Every 2 to 3 years, he developed a recurrence of that granuloma. It becomes active, starts exuding, vision starts going down. It's not active infection, but the granuloma somehow, the vascularization never went away. So the vascularization tends to persist. So you give them a couple of shots over 2 months and they go back happy for next 2 years. So that has been the experience. And that,
well, that kind of turns it topsy-turvy, sir. I mean, we're not getting rid of the bacillus.
No. Probably after a while, the vessel is not the driving factor. It's the local homeostasis has been disturbed. And now I think I favor this autoreactive concept because antigens you can't get rid of. You can't get rid of the MTB antigen once it is there. Proteins you can't, there's no way. But you can kill the MTB.
In certain phenotypes, maybe not in serpiginous-like.
No, I'm sure serpiginous-like is recurring because the MTB antigen is probably that this is the one where I think major role is by autoreactive or autoimmune or autoinflammatory component. These are the subjects which need extensive research and exploration.
Right.
In fact, we don't have a single animal models to develop the clinical phenotype that we see in humans.
Right.
The rapid.
Neil, we can skip the next 4 questions and go to the 5th one, which is by Dr. Anshu. And if everybody agrees, we can come back. We go next. Yes, this is the one. Yeah, Anshu, please go ahead. And Anshu, you could also ask the question which you put on the YouTube. Go ahead with that.
Yeah, so this is regarding one of my patients, sir and ma'am, that I wanted to have your word about. This particular girl, she's around 31-year-old. She came with a picture very suggestive of intermediate uveitis. And after investigating her for mainly tuberculosis and sarcoid, which came negative, and following the Kaplan regime, I started the patient first on PST, subtenon steroid. And she responded well in the initial phase, that is roughly around 4 years back. Following this, she had, kind of recurrences coming back after every 3-4 months when the PST, the tricot effect faded off. So slowly she, went into the treatment with oral steroids. Since she had initially she was unilateral inflammation, she had unilateral inflammation, and then she started developing this bilaterally. So following this, I kind of investigated her further, and her immune connective tissue profile was also done, and she was negative for that too. Her MON2 was around 10 millimeter, and ACE levels were normal always. This was checked again after some time. And her chest CT had a small fibrotic lesion in the left upper lobe, which had no activity. Now, in one of the eyes, that is the right eye, she, after 3 years of treatment, she started developing a serous retinal detachment, and which was reaching up to the inferior arcade. So this serous retinal detachment, in spite of, after steroids and later when I started around mycophenolate and methotrexate too, it is kind of persisting. So it's a chronic non-infectious uveitis, which I treated with all systemic steroids and IVMP also at some juncture. And her macula is attached, but she continues to have persistent extramacular RD. Any suggestion how to manage as the SRF is gradually progressing towards the macula?
I think the development of a serous detachment is not really a feature of intermediate uveitis. The only type of uveitis where we see serous detachment is leaky sympathetic, or sometimes next to the granuloma, which are very exuding kind of granulomas. So if my patient of uveitis develops serous detachment, I would look for two things. The first one would be development of central serous chorioretinopathy, secondary to the steroids that I have used. And it's always a good idea to repeat the fluorescein done, even if you have got it done before, to look for any point leakage which is hyper in the early and hyper in the late, even if it's expanding a little bit. So that will give you a clue, because your patient sounds to me more like CSE induced by steroids rather than anything else. The second is, which probably your patient may not have, but some of this is venous obstructive corroidopathy. So many patients of this spectrum, which we used to call pachychoroid earlier, and now it's, obstructive venous corroidopathy. So they can also have inflammatory mediators increased, and all these UES and all, they all become a part of spectrum. So just do a good autofluorescence if it is not CSE, and look in that direction. But first I would rule out CSE.
I have in fact ruled out CSE. I've done an angiogram, repeat angiogram. And in fact, I weaned her off steroids when I suspected that. That was the first thing which came to my mind too. It's like a teardrop CSR in one of the eyes, but she had no particular point leak or multifocal leak as we usually see in CSE. Yes, she had
autofluorescence with gravitational tracts. If you are
right, so
gravitational tracts, it's not uveitis. It's not, the current problem is not uveitis.
Right. So do you think, another small question is that, do you think such younger patients, is it beneficial to start them on biologics rather than, if it is BKH, suppose, so do you start on,
most
do you
of
think
our patients, yeah, young patients, the JIA patients, nearly 100%, and intermediate uveitis, which is of the severe variety, non-infectious, biologics are very well tolerated compared to the traditional immunosuppression. So these patients, the uveitis can be controlled very well on.
Yes, because I have a similar patient with BKH whom, she was earlier misdiagnosed as papilledema somewhere and was started on steroids, and later I shifted her to biologics, and she's doing pretty well for quite some time. And this adds to one small more question, that if a BKH is stable, like you don't see the activity post biologics, what are the signs you look for an early recurrence, or how do you follow?
To be honest with you, I don't treat my BKH patients with biologics. I treat more severe forms of uveitis like JIA, Behçet's for sure, and panuveitis, especially in children, non-infectious varieties, because BKH to me still responds very well to IVMP and immunosuppression, which typically is azathioprine or methotrexate, or MMF right now with us. And, we generally start it very early in the course of the disease. The way to look for recurrences is to look at the choroidal thickness. Choroidal thickness will start increasing. Sometimes the patient does complain, if they are, the sensitive patients, of little bit of discomfort or some distortion. So if you see choroidal thickness increasing, and if you have OCT angio, you may see those dark spots of capillary flow void, or whatever you call them, coming even before the appearance of two granulomas. But many times the recurrence in a well-controlled BKH may not come in the posterior segment. It might just come as an anterior segment inflammation. So if you see only anterior segment inflammation, start on topical steroids, get an ICG done to see if there is any subclinical disease somewhere in the choroid. If you find, then you need to go for the systemic increase in the therapy or whatever. If the patient is not, then restart. But if the posterior segment is well controlled, many a times you can get away not altering this systemic therapy, but just adding topical steroids.
Right, ma'am. Thank you so much. We have a lot of questions, but I think
we have overshot the time.
9:22. If people who would like to quit and say this dinner time, we can close it off. I still have energy to go.
All the time.
But
I think sir and ma'am also need to.
Need some rest. So I think, let me ask Urvashi, Charu, Anupma, if you have any questions, because everybody must get a chance to. If you have any questions you would like to ask, Urvashi and Charu?
This is a golden opportunity.
Yeah. I'm sure we'll have this opportunity again.
We can have as many sessions as you feel like.
Yes, thank you
Yes,
so much.
I think we've only done half the questions.
Yeah. So we had another set of questions.
If you really want to create a brigade of uveitis experts,
exactly,
you need to give them chance to ask questions and have one-on-one
discussions. Can we take it as a promise from you, sir, that if we ask you again, you will never refuse?
I am available every day.
Ajay, why I wanted sir and Dr. Vaishali was they don't teach you uveitis, they teach you how to think. In their answers, they will tell you how they went about and came to this conclusion, and which is what I wanted to.
So let me just ask the last question,
let me just say
which is important. Sunil, can you put that up? The last one.
The last slide, yes. That's a nice
last
one.
slide.
And then we'll have Urvashi's comment.
Yeah. Urvashi and Anupman. So this is what I want to ask both of you. Both of you have done amazingly well in uveitis. Being present at PGI at the right time mattered. how do you go about enhancing your knowledge and skills in uveitis? What is your massive message to the youngsters? I think we talked about it earlier, but just I want Professor both Vishali and Professor Gupta to sum it up and tell the youngsters that this is an exciting disease to look for, and if we how do you go about it?
You see, my chief told us when we were residents, because he used to be all the time snubbed by his fellow colleagues in other disciplines like surgeon, physician, internist, this, that. And he said, no, I'm no less, because he was UK trained. And he said, I'm no less a physician. So he always had great interest in systemic diseases. And that is how I got interested primarily in these, because, I used to do a lot of retinal surgery. I was, even till the end, I was doing a lot of retinal surgery. But Ajay, you would realize retinal surgery don't pose a challenge. I mean, you do one case of retinal detachment or 100 cases, or you treat one diabetic or you treat 1,000 diabetics. It's the same, or CNV, and you keep repeating the same thing over and over again. That can be very, very boring and tiresome. Okay, here it is an opportunity. Patient presenting, you can act as a physician to that patient. You start thinking about what he may have in his eye, what he may have in his system. You think like a physician, a comprehensive physician. And that is what we, I think, practiced, and we had the advantage of having people like Professor Bambri, who started working with me way back in 87, and followed by Aman Sharma when he went away, who's the professor of rheumatology, who got, Bambri learned how to do a slit lamp exam and indirect ophthalmoscopy. Believe it, because they found it very exciting. So did Aman Sharma find it very exciting. Because eye is the only organ in the body where you can see the pathology unfolding. There's no other part. You have to have access to the labs or X-rays and CTs and all that. So here they were actually seeing what they read about pathologies. So this is an eye, to the rest of the body. So that got me interested, and the disadvantage was that we had to learn everything. Even treating the first toxoplasma patient, I'm sure Vishali would remember all those. We had a tough time deciphering. And I'm so envious of the young people who are joining their MCH course and fellowship course in PGI. They have so much more and so quick learning. Something, we learned over 10 years to focus on get a good retinal angiogram, or 1 year to focus even the retinal picture. They can learn in a day. So it's very, very quick learning these days, because now we have the experts. We have, I think, a good pool of experts in this country. We need, for 1.4 billion people, we need many more, hundreds and hundreds of experts.
Professor Vishali, what is any comments from you?
I agree. I also learned everything from my chief, like Sir did from his chief. So Sir taught me the value of talking to the patient, understanding the patient, just taking history and talking to the patient will help you reach diagnosis, or at least lead towards the diagnosis. Because in ophthalmology, we don't talk to the patients. In ophthalmology, we don't talk to the other specialities. So we need to, like, I call most of them just on phone that this is the patient, how, and because if you send a patient to somebody, they don't understand what you want. So if you have to work in a multidisciplinary team, you have to have a very cordial working relationship. And I think now is the era which I'm very much interested personally moving towards is precision medicine, pharmacogenetics, to find a way what is going to work for which patient, and customized therapy and even customized imaging. I get very confused with everybody trying to show so much imaging, and I think there has to be targeted imaging, not only targeted labs. And you have to treat every patient as very differently. And I don't think we can, in uveitis, we can just follow any book because every patient has a different story. Like even for TB, some patients respond to anti-TB, some respond only to steroid, some only to anti-VEGF, and some patients keep coming back whatever you do. So I think every patient needs a very, very individualistic therapy rather than generalizing the do's and don'ts. That's
one last question, ma'am. I think just Professor Amod said that, about the wide field imaging, which you described, those
Paradoxical.
Paradoxical worsening. So do you, in most of your patients, get a wide field imaging done?
In uveitis, yes.
In uveitis, yeah.
Yes. I told my only lab, I have been working on it, that our team should not be doing those riff-raff OCTs, fluid plus, give injection, with the home OCT devices available now, we should be having our technicians just doing the OCTs along with the IOP, and our team should be dedicated mainly to do these wide field ICGs and fluoresceins for the patients who really need attention. Yes, I do.
You think wide field OCTs and wide field imaging is going to be the next big thing in uvea and retina?
I don't say for every uveitis patient you need, but probably the kind of the patients we see who have gone through all, it does help you a lot. And even in the patients who do not have very clear media, once you get the ICG, you get a fair enough idea what you are dealing with. So I get it done a lot.
Thank you, ma'am. Urvashi, anything you want to say, or Charu or Anupma? Yeah, Charu, go ahead.
So I don't want to ask a question. I want to thank Professor Dr. Amod Gupta and Dr. Vishali Gupta for sparing their valuable time. And I'm sure the salient points and the telltale signs they have described will going to help us in our normal OPD patients. Thank you so much, sir and ma'am. Thank you.
Okay, everyone. Good night.
Thanks a lot once again, and thank you for all for joining.
My pleasure. Okay. Thank you. Thank you so much.
Thank you, sir. Thank you, Dr. Vishal. Good night.
Good night, ma'am.